Welcome to the Explainer. Today, we're going to break down the clinical pathway for Group A strep pharyngitis, all from a pharmacist's point of view. We'll hit everything from assessment and diagnostic tools to the first-line treatments and, of course, the crucial patient counseling that really makes a difference.
Okay, let's dive right in. We'll kick things off by figuring out when a sore throat is just a sore throat and when it's something more. Then we'll walk through the diagnosis, how to pick the right antibiotic, focus on your role in patient counseling, and wrap it all up with stewardship and some special cases you'll definitely see.
First up, let's tackle the question we get all the time at the counter. Are we dealing with a virus here, or is this actually bacterial?
So we all know that the vast majority of sore throats are viral. But Group A Streptococcus, or GAS, is the most common bacterial culprit, and it's the one we absolutely cannot afford to miss. Not just for symptom relief, but to prevent some really serious problems down the line.
Now, this is where it gets interesting. Look at the clear split here. In adults, GAS is only responsible for, maybe 5 to 15% of sore throats. But check out the kids. That number jumps way up to 20 or even 30%, especially for those between 5 and 15 years old. That's a huge clue for us right from the start.
And this slide gets to the heart of it. This is the why. Why are we so diligent about treating strep throat? Well, the main reason, the number one goal, is to prevent acute rheumatic fever, or ARF. It's a rare but, truly devastating complication that can cause permanent damage to the heart valves.
So with the stakes being that high, how can we systematically figure out the odds of it being GAS, right there in the pharmacy, to help guide our patients? One of the best, most practical tools we have is the modified Centaur score. It helps us put a number on the probability of GAS based on what the patient is telling us. You get a point for a fever, a point for not having a cough, and so on. The magic number is 3. If a patient scores a 3 or higher, that's a really strong signal that testing is probably a good idea.
And when it comes to testing, you've basically got two options: the rapid test, or RADT, and the old-school throat culture. The rapid test is awesome because you get an answer in minutes. The problem? Its sensitivity is only about 80%. And that means, and this is a big deal, for kids, a negative rapid test just isn't good enough. It should always be backed up with a culture to be sure.
All right, so you've got a confirmed case of gas. Now comes our next critical job, picking the right antibiotic to knock this thing out and prevent those complications we've been talking about. The undisputed champion, the drug of choice, is penicillin V or amoxicillin. It's just the perfect tool for the job. It's narrow spectrum, so it doesn't cause a ton of collateral damage. It's safe, it's cheap, and get this, clinical resistance of Group A strep to penicillin has never been documented. It just works, every time.
And the duration is just as critical as the drug itself, a full 10-day course. This is non-negotiable. It isn't just about feeling better in a few days, it's about achieving a complete bacterial cure to slash that risk of developing acute rheumatic fever.
But of course, you always have to ask about allergies. And with penicillin, the next step depends entirely on the kind of reaction. If it was a mild, non-severe rash, a narrow-spectrum cephalosporin like cephalexin is a solid choice. But if we're talking true anaphylaxis, hives, trouble breathing, that's a hard stop. You avoid cephalosporins and you go for clindamycin or a macrolide instead.
Okay, now let's move on to what is arguably the most impactful part of our job. Once that prescription is filled, our counseling is what makes or breaks the therapy. It's how we make sure it's safe, effective, and actually understood by the patient.
So here's a super simple 4-step checklist for every single strep throat consult. 1. Hammer home adherence. You have to finish the full course. 2. Manage their expectations by explaining the common side effects. 3. Give them some real value with advice on symptom relief, analgesics, fluids, rest. And 4. Make sure they know the red flags for when to call the doctor.
And when you're counseling, it's not one size fits all. You've got to tailor it to the specific drug. For penicillins, you're mostly talking about potential stomach upset. But with clindamycin, while you absolutely have to warn about the risk of significant diarrhea and C. diff colitis and tell them to seek medical help if that happens, it's a critical point.
To round things out, let's talk about our vital role as antimicrobial stewards and touch on a couple of special populations that you'll definitely encounter.
You're going to get asked about pregnancy and breastfeeding all the time. And the great news is, you can confidently tell them that our first-line agents, and even the common alternatives like azithromycin and clindamycin, are all considered safe to use. Just add that little caveat to keep an eye on the infant for GI issues if mom is taking clindamycin.
Now, for a little dose of perspective. While antibiotics are absolutely essential to prevent ARF, this quote shows their impact on symptoms is, well, it's pretty modest. Patients on placebo often feel better on their own by day 7 anyway, and that's a really critical thing to keep in mind when we're weighing the pros and cons of antibiotic use.
And that brings us to a key principle of stewardship. It is perfectly safe to watch and wait. Delaying antibiotics for a day or two while waiting for a culture result does not increase the risk of ARF. Period. Embracing this can prevent a huge amount of unnecessary antibiotic use.
And this leaves us with a final question for you to think about in your own practice. You have a patient who's at low risk for complications. The test is positive, but their symptoms are super mild. Does that small benefit in symptom relief really outweigh the risks of antibiotic use, like side effects and resistance? It's a tough, nuanced question, and answering it is at the very heart of modern antimicrobial stewardship.